Good evening. Ready for another infectious disease Puscast? Where does the time go? This one covers the last 2 weeks of January 2010. It's on iTunes as always. Go on iTunes, write me a review. You cannot know how much it means to my fragile little ego to know that you love me. You really love me. This is brought to you, as always, by Pusware LLC, publisher of the Persiflators, the annotated compendium of infectious disease facts, dogma, and opinion. Your uber-hyperlinked electronic guide to infectious diseases at pusware.com. Since this is CME accredited, and when you're done, you can take the perfunctory quiz and get a half an hour of free CME, thanks to Legacy Health Systems, I must mention the lack of conflicts of interest. And I've lied to you all these years. It was pointed out to me that I do have a conflict of interest, that I have accepted something from a pharmaceutical company. Years ago, the Unison rep, when he left the institution, sent me a Fleets enema with a Unison sticker on it, and I kept it. So I can't say that I've never taken anything from a pharmaceutical company. As always, join my worldwide multimedia empire. Included is the Quackcast, the Gobbet of Puss, 2 great podcasts, and my blogs. Well, one of them is mine, Rubor, Dolor, Kalor, 2 more, my ID blog over at Medscape, and of course, Science-Based Medicine, where I babble away twice a month. The literature, as always, is available online. Now, let's move on to the papers at hand for this month's Puscast. I shall start, however, with an announcement. The Persiflators Annotated Compendium of Infectious Diseases is soon to be an iPhone application. Who would like to be a beta tester? Or for those of you in England, a beta tester? If you're interested, send me your name, your email, and your UDID. To get that, you need to get the information from your iPod Touch or iPhone and click on the serial number, and you'll see this hideously long alphanumeric number. That is the number I need to put your iPhone or iPod Touch into the beta testing pool. I'm limited to 50, and I already have 10 people lined up, so actually I'm limited to 40. If you're interested, send me an email with that information and put beta tester in the subject, and I'll get you on the list. If you also put in the body that you actually were fool enough to send me a donation, I'll move you to the top of the list. Because you know the motto of this Puscast, no good deed goes unpunished. And now, on to the real literature. This study was out of Italy and concerns how clean the water is there. Now, we know that the River Po is filled with, amongst other things, cocaine. That was an interesting study. But they took tap water and carbonated and non-carbonated water coolers and checked them for bacteria. And they found that the one organism that was consistently located in the water was Pseudomonas species, which they found in 20% of tap water in this city in Italy, but 50% of the sources taken from the water cooler. They also found Stenotophomonas pastorella, Enterobacteria, and Flavobacterium in the non-carbonated and carbonated water coolers. So when you gather around the water coolers to talk about last week's It's Always Sunny in Philadelphia, you will also be exposing yourself more likely to pseudomonads. No big deal if you're a normal person, but if you're immunocompetent, at least in Italy, the tap water is safer than the water you get from the water coolers. Worldwide, one of the leading causes of death is diarrhea, and it kills children by the bucket loads in the third world. One of the causes of these diarrheas, of course, is the rotavirus, and there is a vaccine available for the rotavirus, developed by Dr. Paul Offit, you may know of because he's one of the leads in the anti-vaccine wackaloon fight. Anyway, this is a pair of studies that looked at the efficacy of the rotavirus vaccine. When it was used in Mexico, they found a decrease in diarrhea-related mortality from 61.5 deaths per 100,000 children to 36 per 100,000, all occurring after the institution of the rotavirus vaccine. A similar study was done in Africa, and it demonstrated, in a randomized placebo-controlled trial in South Africa of 3,100 infants, a marked decrease in severe diarrhea from 6.7 to 4.2 cases per 100 infants vaccinated. They estimated that the efficacy of all-cause severe gastroenteritis was 30.2%, which is pretty good considering the mortality and morbidity associated with diarrhea of all types, including the rotavirus, in the third world. The vaccine, as used in the United States, is a live virus, although attenuated. And in the same New England Journal of Medicine with the prior two studies was the report of 3 infants, all of whom had rotavirus in their stool. They all had severe combined immunodeficiency and got a bad case of rotavirus diarrhea as a consequence. 2 of the 3 were cured subsequently with stem cell transplant, which was done for the primary immunodeficiency, not for the rotaviral infection. But again, no good deed ever goes unpunished. In an attempt to treat large numbers of people with vaccine, especially with live virus, one needs to be careful not to give it to the immunodeficient, which is difficult to do, sometimes determine in the very young, especially when the underlying immunodeficiency is also very rare. DDI was one of the first nucleoside reverse transcriptase inhibitors used for the treatment of HIV disease. And those old geezers, such as myself, remember the occasional patient who came in with lactic acidosis and hepatic steatosis. Now there is a new complication associated with DDI. There's not been a lot of cases, but they've all been reported to the FDA, and for a total of 42. And what it causes is non-cirrhotic portal hypertension. Of the 42 patients, 4 died, 2 from esophageal varices, 1 from liver failure, and 1 from multi-organ system failure. They did transplant 3 patients who survived. So portal hypertension, not due to cirrhosis, may be a long-term side effect of DDI, aka VIDEC, and VIDEC-EC for those of you who don't speak generic. I have blathered away in prior podcasts about the importance of treating herpes in patients with HIV. Patients who have their herpes suppressed tend to have fewer ulcers, which may be important in transmission. They also tend to have a slower progression of HIV and lower HIV in their blood. Probably by suppressing the immune activation, you decrease HIV replication. But does it prevent the spread of HIV? The big answer for this is, unfortunately, negatory function. In this article in the New England Journal of Medicine, they looked at 3,400 couples in Africa, and they gave patients who had HIV and HSV daily suppressive acyclovir. And unfortunately, it did not decrease the spread of HIV in discordant couples, despite the fact that they did better in terms of both HIV levels, which were modestly decreased, and a marked decrease in the number of genital ulcers. The CCR5 receptor. The CCR5 stands for Creedence Clearwater Revival, and you can find this receptor down on the corner. Actually, it stands for CC chemokine receptor, and this receptor has been shown in the past to be important for HIV transmission, and patients who are deficient in this receptor cannot get HIV. Unfortunately, the downside of this receptor deficiency is an increased risk for severe West Nile disease. And in this study, which looked at patients with or without the CCR5 receptor, found that them what had a receptor complete loss of function had worser West Nile disease, both early and late. Now you may say to yourself, well, big deal, there's not a lot of CCR5 receptor deficiencies out there. Well, the other problem is we are making people CCR5 deficiency. There's an HIV medication called Maraviroc, which sounds like some sort of Greek god, that is a CCR5 blocking agent. So you'd predict that people on this particular agent would have worser West Nile virus should they get exposed to West Nile. By the way, if you're wondering what the frequency of this mutation is in the United States, in this study it was 2.4%, and other studies have suggested it's between 0.7 and 1.7%. However, the incidence in the city of Lodi may be much higher. Does the influenza vaccine prevent death in the elderly, and if so, how much? It's been argued that because those who had the vaccines have less death rates, then perhaps it's protective in population studies, but there have been them what have not believed that and have suggested that it's selection bias, that healthier people get the vaccine and healthier people are less likely to die. This is confirmed in a CID report where they looked at patients and their probability of death and their probability of getting the vaccine. They found that as patients got sicker and they had a higher probability of death, their chance of getting the vaccine plummeted, so that those with the highest risk of death were those least likely to get vaccine. So a significant part of the efficacy of the flu vaccine for preventing death in the elderly may indeed be to the fact that the people who get the vaccine are healthier and the people who don't get the vaccine are not. So given the selection bias, it's difficult to state how good the vaccine is at preventing death in the elderly. As the discussion says in the paper, no matter what results we use for looking at efficacy, quote, the vaccine will prove to be less effective at preventing death than was previously thought, end quote. You don't know how much it pains me to say this. Of course, being a big proponent of vaccines, I'm still a big proponent of the influenza vaccine. And as this article points out, says, well, the best way to prevent influenza in the elderly may be to prevent them from being exposed, and that the vectors that bring it home, i.e. kids and young adults, who do tend to respond much better to the vaccine than do the elderly with comorbid conditions, need more aggressive vaccination to prevent its spread to the older population. You know, sort of the altruistic, I'll get the vaccine to prevent my grandma from dying. But as always with these issues, the more you learn, the grayer it becomes. Flu kills people, as does bacterial pneumonias. And it's long been suggested that if you get influenza, you're at higher risk for bacterial infections, especially about a week after the onset of the influenza. This was a huge study that looked at 185 million person years of surveillance. They found 21,000 cases of invasive pneumococcal pneumonia. They tested these for influenza as well, almost 500,000 of them. And they found that influenza circulation was associated with about 11 to 14% of the pneumococcal pneumonias during the influenza season, and it tended to lag by about a week. So you get a spike in influenza and then a week later a spike in invasive pneumococcal disease. One would hope that if you prevented the influenza, you would then prevent the pneumococcal disease. I'm sure that things are not as simple as that. The etiology of community-acquired pneumonia has always been difficult to diagnose accurately, mostly because blood cultures are often not positive, and the sputum is a notoriously unreliable specimen to get samples from. It's contaminated, and or the patient doesn't honk up a loogie for you for analysis. This study out of the Karolinska University Hospital did the Uber workup on patients with pneumonia, and they were actually able to get a microbiologic diagnosis in almost 90% of their patients by doing a variety of cultures, PCRs, and urinary antigens. They must have spent $1,000 or more on each case. Interestingly, is the breakdown of causes of pneumonia. Of the 30% who had bacterial pneumonia, 38% had strep pneumo, followed by mycoplasma, Haemophilus, Moraxella, staph, and a piddly 1% Legionella pneumonia. The Karolinska Institute is like Portland, Oregon in that respect. we don't see a lot of Legionella here either. The other percentage was viral infections, and they had quite the hodgepodge, including influenza, rhino, RSV, parainfluenza, coronavirus, metapneumovirus, adenovirus, 2 herpes viruses, and 1 enterovirus. So there's a huge hodgepodge of viral causes of pneumonia as well. And not infrequently, the patients had more than one organism found in their respiratory tract, a whopping 35% of the time. So for community-acquired pneumonia, it would appear that not only if you really want to spend the bucks, you can get a diagnosis most of the time, not infrequently, you will find more than one pathogen. Besides a good 5-cent cigar, what this country really does need is a good, simple way to diagnose multiple organisms from a sputum sample with high reliability. We also need peace in the Middle East, and we need universal health care coverage. I don't think we'll see any of the above in my lifetime. When I was at the Amazing meeting this year, which, by the way, is amazing, I went and saw Penn and Teller, and part of their act is a fire-eating shtick by Penn Jillette. I did not know there is such a thing as fire eater's lung until this week, which is a lipoid pneumonitis from inhaling the flammable agent. There was also a article, a case report at least, of fire eater's lung, which was complicated by an infectious abscess requiring surgical debridement. So I guess the flames were not sterilizing the lung, and that you can get a pneumonitis from being a fire eater. Who would have thought it? Be careful, Penn. But people who listen to this podcast or Puscast know that I love these weird-ass associations. I've talked in prior podcasts about the various and sundry ways one can get Legionella, including there was a downwind outbreak from a cooling tower that led to Legionella. How often is this a problem? Well, this study, they actually went and looked for Legionella in cooling towers. And again, I love this weird kind of stuff. They looked at 96 cooling towers and found that almost half were colonized by Legionella. They found Pneumophila as a predominant isolate, and they found it in high levels in these cooling towers. They would find greater than 10 to the 4th colony-forming units per liter. So let me give you some Clintonian advice. Don't inhale. There, for the grouchy bastard that says I rag on Bush too much, there's a Clinton joke for you. You happy? Don't say that the Puscast does not listen to even its whiniest listeners. But the real take-home is if you happen to have a case of Legionella pneumonia, you really need to take a careful water exposure history, looking for cooling towers, fountains, etc., etc. As I mentioned once, there was even a study that showed you could grow it in puddles on the roadside after rains. I don't know why we don't see more of it in Oregon. Again, to the theme of no good deed going unpunished, the use of inhaled corticosteroids is the mainstay for treating things like COPD and asthma. And again, it's not without its risks. There was a study published in the journal Primary Care Respiratory Journal, the Journal of Journals, and they looked at the risk of developing pneumonia in 2,100 patients. And they found that the use of inhaled steroids increased the risks for the development of bacterial pneumonia, but not seen with the use of long-acting beta agonists. So the risk for developing pneumonia in patients with COPD went up if they used inhaled steroids. The same, unfortunately, is true for tuberculosis. This study out of Taiwan looked at 36,000 people, and they found 554 who developed tuberculosis. They found that the use of inhaled steroids, as well as oral steroids and prior pulmonary TB, were all independent risk factors for the development of active pulmonary TB. So inhaled steroids increase the risk of both regular pneumonia and tuberculous pneumonia. It's tiny, but it's real. I like the term Andalusia. It sounds so romantic. This study looked at the outcomes of left-sided endocarditis in an Andalusian multi-center cohort. A part of Spain is Andalusia. They looked at prognostic factors, and it was the usual, and it was not surprising. Things that increased mortality were prosthetic endocarditis, okay, Staph aureus, sure, severe heart failure, neurologic manifestations, septic shock, perivalvular extension, and acute renal failure. Yeah, no surprise there. But now, and here's the key thing from this study, surgical treatment was protective. Now, patients had surgery because they had cardiac involvement that warranted surgery, but still, this is the third article to suggest that surgery is protective in endocarditis. Now, as they said in their discussion, quote, the fact that surgery is an independent protective factor for mortality in our study is possibly related to high number of complicated cases included with heart failure due to valvular dysfunction. However, this data must be interpreted with caution since it is an observational study. However, in another recent study, surgery during an episode of endocarditis either was associated with better prognosis when this variable was analyzed with multivariable regression modeling, end quote. Of course, the was not part of the quote. This has been an interesting result of multiple endocarditis studies of late. The fact that surgery may be protective for long-term mortality. What we need, of course, is a randomized, prospective, blah, 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 blah. So, what's the cause of appendicitis? I don't know. Do you? Well, this study from the Archives of Surgery looked at the etiology of appendicitis, and they determined what it wasn't due to. They did not find it was due to influenza. Big duh there, influenza being primarily a pulmonary infection. Why you would cough through your appendix has always been a mystery. And of course, the concept of stomach flu is a concept of people who do not think clearly. They also found that it was not associated with rotavirus or other gastrointestinal viral infections, so they've mostly ruled out viruses as a cause of appendicitis in this study. And they could not find an association in most cases with fecaliths, which are relatively rare. So what's the cause of an appendix going bad? In most cases, we still don't know. But nonetheless, I've gone through every book in my library and removed every appendix. I'm not going to get into trouble later. I love infectious diseases. But if you're having trouble sleeping, there's always the IDSA guidelines, which by necessity are always boring as dust. There is now the Diagnosis and Management of Complicated Intra-Abdominal Infections in Adults and Children guidelines by the Surgical Infection Society and the IDSA, available at idsociety.org. I won't bore you with the details, but you do need to know that it's out there and their guidelines are available. The CDC this month describes a bunch of cases, 4 to be exact, of strep salivarius endocarditis after having spinal anesthesia. This is a rare complication of having an anesthesia, and interestingly, that 2 of the patients had strep salivarius that were indistinguishable on pulse field electrophoresis, and they had the same anesthesiologist who did not wear a mask. It's always been argued where the strep comes from in patients who get a streptococcus meningitis after a spinal tap or anesthesia. Is it due to the patient's oral pharynx and a transient bacteremia and bad luck, or is it coming from the operator who puts in the needle? That's still uncertain, but this would suggest that at least some of these cases after spinal procedures are due to droplet transmission of oral flora coming from the healthcare provider to the patient. I had one once who had a meningitis after a myelogram, but she was chewing gum through the whole procedure, which is a known way of getting bacteremic. So I would bet that a percentage of them are due to the operator and a percentage of them are due to the patient. But at least if you're putting needles into patients' back, it is not unreasonable, especially with this particular study, to always wear a mask, which, by the way, is the standard of care. The New England Journal this month has a review of nosocomial meningitis, and I'll quote, "The majority of cases occur after spinal anesthesia or myelography. The risk of meningitis after lumbar puncture may be substantially decreased if aseptic conditions are met, i.e. hand disinfection and use of sterile gloves, and if operators wear face masks and operating caps when performing spinal anesthesia or myelography," end quote. And there's not a single reference. Certainly I would agree with the hand disinfection and sterile gloves. The face mask and operating caps, probably, but it would sure be nice if they would have a reference when they do these things, don't you think? You know, every time you think you have a simple solution to a problem, it comes back to bite you in the butt. Now, there was this ICU that had about a 20% incidence of MRSA. So what they decided to do was use chlorhexidine throughout the system. And they did, and they had an immediate and sustained drop in the spread of MRSA in their ICU. However, they selected for a strain of MRSA called TW that has a threefold higher MIC to chlorhexidine than the standard MRSA. And what would you know? But would appear that not only was this organism unaffected by the chlorhexidine, but there was a suggestion that it was spread more rapidly, perhaps due to, I don't know, skin damage due to the chlorhexidine scrub. So just remember, as I keep saying, use it and lose it, and no good deed ever goes unpunished. In the last podcast, we talked about a New England Journal article that looked at patients who were colonized with staph, and if they were given 5 days of chlorhexidine and mupirocin, their surgical wound rates went down. I was wondering whether or not it would be just a better thing to give everybody chlorhexidine and mupirocin before their OR. Now I'm not so sure, as we'll probably end up with the chlorhexidine-resistant strains in our units by doing this. On the other hand, there's significant cost for screening everyone for staph, not just MRSA, and you can carry it in more places than just the nose. So now I really don't know what to do for these patients. There was an interesting observational study out of Tennessee that looked at the rates of extrapulmonary TB by race and sex. They found, I'll just give you the results, extrapulmonary tuberculosis per incidence, 100,000 population was 5.93 in black men, 3.21 in black women, 1.01 in non-black men, and 0.58 in non-black women. Now that was the incidence per 100,000. Now if you actually had tuberculosis, you're more likely to have extrapulmonary TB if you were a black female followed by a black male. And lastly, non-black men were the least likely to have extrapulmonary tuberculosis. There's been a bunch of literature about the genetic predisposition due to alterations in toll-like receptors for developing tuberculosis, for developing invasive tuberculosis, etc. One would wonder about the toll-like receptors in these groups and whether or not there was variations that led to this increased predilection for extrapulmonary tuberculosis, although HIV status was not noted in a significant number of the patients. And we'll finish with the usual hodgepodge. How about Canada bloodstream infections? Well, this looked at treatment over a 3-period time. They had the amphotericin era, where they had a 48% mortality rate for fungemia, followed by the triazole era, i.e. fluconazole, where the death rates then fell to 32%, and then the echinocandidin era, where death rates fell to 10%. The conclusion is that echinocandidins are associated with a better outcome. Actually not a great study, but still it goes along with the fact that if you have suspected or known candidemia, you should probably start with an echinocandidin up front. The next study looked at length of surgery and infection rate, and not unsurprisingly, the longer your surgery, the higher the chance of developing an infection. And the rate went up to 31% for cases of more than 6 hours. So, work fast, would you, surgeons? This was a study in JAMA, but tight glucose control did not help in septic shock. And so my critical care colleagues are still having to figure out what to do with glucose control in the ICU. Burkholderia pseudomallei, the cause of melioidosis, can be found in tomatoes. So be careful when eating your tomatoes. There was a study done by the developers of the product that showed that monoclonal antibodies prevented relapse of C. difficile. They had 2 monoclonal antibodies directed against the C. diff toxin that were given one time intravenously to patients with C. diff, and they had a decrease in the relapse rate. Finally, and I know that for vacation over spring break, you're all going to go to Denmark and deal with the dairy herds. Just so you know, 59% of dairy herds have positive antibodies for Coxiella burnetii, the cause of Q fever. So be careful around those dairy herds. And so we come to the end of another Puscast review of the infectious disease literature, covering the last 2 weeks of January 2010. Now that you're done, you can go online, take the perfunctory quiz, and get free CME. Just don't let people know that I consider the quiz to be perfunctory. As long as you're at it, go on to iTunes and write a glowing review of what a stupendous podcast this is. And of course, participate in the rest of my multimedia medical empire, including the Gavato Pus, the Science-Based Medicine blog, the Quackcast, and Rubor, Dolor, Kalor, Tumor. Because the world needs more Mark Crislip. This is copyright 2010 under the Creative Commons license. The music was by my son when he was 12, improvising on the guitar. You can send me email, but I think I'm up to about 1,500 unanswered emails now. So the chances that I will respond to your email are fairly minimal, but not exactly 0, but pretty close. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you, in dictation, and goodbye.